Thank you. Good evening. I'll try to be quick because I guess you are a little tired at that moment of the day. Let me introduce you quickly the TasP ANRS 12249 trial. So the main hypothesis of this trial was already formulated 5 years ago. And the idea was HIV testing of all adult members of a community, followed by immediate ART of nearly all HIV-infected participants, regardless of immunological or clinical staging, so what we call universal test and treat, will prevent onward transmission and reduce HIV incidence at population level. The TasP trial area is located in rural KwaZulu-Natal in the subdistrict of Hlabisa. It's close to the HIV surveillance of the Africa Center for Health and Population Studies, but it's just in the north. It's Zulu-speaking people with an HIV prevalence around 30%, high unemployment rate of around 80%, and we are working in an area where also Department of Health has been here for a very, very long time. There is 3 clinics from the Department of Health located in the trial area. It's a cluster randomized trial. What is quite specific is that the trial started, in fact, in 2012 in only 4 clusters, in red on that picture. Then 6 additional clusters have been opened in 2013 in yellow. And finally, 12 additional clusters have been opened mid-2014, which means, in fact, that we have for few people now quite 2 years of follow-up, but for most of people in the trial, we just have less than 1 year of follow-up right now. So it's a cluster randomized trial with 2 arms. Each cluster has a population of around 1,250 adults, 6 years or more. And the TasP intervention has 2 main components, universal repeat testing and early treatment. In each cluster, both control and intervention clusters, we are implementing rounds of home-based HIV testing every 6 months or more or less 6 months, which means that every 6 months we are going to visit each household to make a list of all people living there. We have questionnaires with socio-behavioral information. We are collecting dry blood spots for estimating HIV prevalence and HIV incidence. And we are offering rapid testing for HIV to people who are not self-reporting being HIV. All people who have ascertained HIV positive because they are self-reporting being HIV positive or because they are tested positive have been referred to local TasP clinics, and we have 22 clinics, which means 1 local clinic for the trial per cluster, in addition to the clinics of the Department of Health. And some people could prefer to stay in Department of Health clinic if they don't want to switch to the trial clinics. The second component is different in control cluster and intervention clusters. So in the trial clinics, in control clusters, we are proposing treatment according to national guideline. So we started with less than 350 CD4 counts, or W stage 3 or 4, and in January 2015, we changed to 500 following national South African guidelines. And the intervention clusters, every adult is eligible for treatment regardless of CD4 counts. So the current package of intervention we have within TasP is home-based HIV testing. Clinic-based HIV testing was proposed for individuals who were refusing to be tested at home, but finally very few of them came to the TasP clinic to get HIV tested. We have a clinic-based ART program, and we are also providing ART counseling within the clinics. In June 2013, we also added some additional interventions. In particular, you have a phone call of a home visit for people ascertained HIV positive but not linked to a TasP clinic within 3 months. Also, if someone is missing a clinic appointment, you will have a phone call the same day by the nurse, and sometimes we just have another appointment made, and in case you need additional support, we have a tracking team for patients not reached by the nurse or requiring additional support. So what are our first results? So this is the results of what we've called phase 1, which means what was collected from the beginning to end of May 2014 only is the 10 first clusters. In these clusters, we have organized for 6 of them 2 rounds of off-base survey of testing, and in 4 clusters, 3 rounds of HIV testing. First of all, and we have a sort of comparison with some of the assumptions we had, because before the trial we have a sort of modeling to try to estimate what could be the impact of intervention and what is the observed value. First, we were thinking that we will be able to contact 90% each time. In fact, we have a contact rate per round around 67%. It doesn't mean that only 67% of people have been contacted, because we contacted people or trying to recontact them in different rounds. So in total, we have around 85% of people ever contacted. Here it's a contact per round. HIV ascertainment rates, so which means that people have said, I'm HIV positive, or they accepted to be rapid tested, is around 70%, not from the hypothesis of 80%. And then one of the more difficult indicators is about early linkage to care. So initially we have the idea that 70% of people will link quite quickly to care, and entry into care within 6 months among individuals who are not already in care when we visit is only around 50%. However, here it's only early linkage to care, and just more our recent data show that you have some people linking quite quickly, and then linkage is increasing slowly but continuously. It's just that things take more time than expected. The out coverage at the beginning of the trial was 39%, as expected. The prevalence observed in the 10 first cluster was a little higher than expected, 30%. Also, with the new 12 clusters, things will be probably a little different because we'll have some more rural clusters. And finally, the observed incidence was, in phase 1, quite similar to what we expected. We tried to estimate the cascade of HIV care at the end of phase 1, which means end of May 2014. So that graph, it's preliminary results. We still are working on some data cleaning, but it's only on the first 10 clusters. But we are taking into account both what's happening in our trial clinics and in Department of Health clinics. And we also included non-observed HIV positive people living in the area, so we tried to have an estimation of the overall population in our trial area. And what we can see is that a lot of people were already diagnosed for HIV. So the increase of home-based testing in terms of diagnosis is not so much. But in fact, home-based testing has also other impact, because we have seen that quite a lot of people were already diagnosed, but not in care. So by coming again, we can refer them to care. And also we have met quite a lot of people who have been diagnosed, who came to care, who were lost to follow-up. And once again, home-based testing has been a way to make them to re-enter into care. So finally, the impact you can see in dark green, it's what we estimated to be the improvement due to the trial. Doesn't mean that this improvement was in our TasP clinics, because sometimes we can, by re-referring someone to care, and that person decides to go to a DOH clinic. So there is quite a difference between the cascade of care at the population level and what's happening within our TasP intervention. So if we think in terms of 90-90-90 targets, the target of UNAIDS is that 90% of all HIV positive people will be diagnosed, 90% of them being on treatment, and 19% of people on treatment being virally suppressed, which is an overall of 73% of people being virally suppressed. What we have right now, it's just 31%, but already much better than a 27% estimated without the impact of the trial. And as we can see, the most important part is the question of is the link between diagnosed and being on treatment. Once people are on treatment, we are close to the 90% of being virally suppressed. But it doesn't mean it's just an issue of linkage to care. It's both testing and linkage to care, as testing is a key to refer people to care, or re-refer them to care. So the implementation of the 534 guideline has been done in the trial following implementation in South Africa and in the same area. So we started to use that guidelines in January 2015. And if we think in terms of powers of the impact about the two arms, well, the problem is much more for the new clusters. So the 12 cluster we just opened last year, because if we think about the first clusters, we already have 2 years of follow-up before the implementation of this guideline. So in last November 2014, we have some conditional power estimates done, testing several scenarios, so taking into account the new guidelines and trying to do several hypotheses in terms of incidence. Because in fact, the power to detect an impact on incidence range from 40 to 95% according to different scenarios, but it depends mainly on the baseline incidence in the 12 new clusters we were just open last year. So we don't have any observed information for these 12 new clusters, and we are currently finishing the current UMBE survey round, the second one, and we need to have 2 rounds to estimate incidence. So probably in July, we will try to do new power calculation, trying to take into account baseline incidence in the new clusters. But for that work, we use at least what was observed in the first clusters. Our data safety and monitoring board concluded at that point that there is no reason to stop the study for futility. We still have a chance to show an impact on incidence, even if we have probably less power than expected. However, even if we don't have an impact, we don't see an impact on incidence, we will have a lot of information in terms of implementation, and there is still a big interest in the trial. But we still have quite good chance to see something. Maybe not an impact as much as we expected from the beginning, but probably we can see something. And the JSMB also recommended the implementation of new interventions to improve the cascade of HIV care and treatments. And so just next week, we have a new data safety and monitoring board with a new interim analysis among the 10 first clusters, because we just finalized the last round 1 month ago is these 10 clusters. And we will be able to see the impact, what we have already in terms of incidence at that moment. So we had, in the last 6 months, a lot of ongoing discussions about a new intervention package. In particular, we need to improve what we are doing at community level, in particular community engagement and the mobilization package we are currently implementing. In terms of HIV testing, we will keep repeat home-based testing, but it's clear that we probably need to implement also mobile testing. In this area, in fact, in the demographic surveillance area, it has been shown that mobile testing was a way to reach people that you don't reach easily at home. So it's not exactly the same people you will reach. Also, we need to have a better communication in terms of options about testing in the clinics and in particular around couple testing. We are also thinking about implementing a lot of things in terms of linkage to care, in particular to have SMS reminder, to have motivational support between weeks 2 and week 6 after I've been diagnosed HIV positive. And for people still not going into clinics within 6 or 8 weeks, we will probably offer the option to have a clinical assessment at home and to initiate treatment at home. But it will be not at home versus clinic, it will be option offered to people. So the idea is not to test one intervention versus another. It's much more to give more options to people because trajectory are not the same. And finally, for retention, also SMS reminders, but also to have a simplified art care for stable patients, probably with 3 monthly clinic visits. So we have also a lot of discussion about how to implement this new intervention package. Should we implement it everywhere? Should we have a factorial design? And so 4 arms with some clusters with the full package and some cluster with a basic package. All these discussions are depend on our next data safety monitoring board conclusion and also our scientific advisory board. Also will depend about the ethical committee, and we expect probably to start something in the second semester this year. Also, we are discussing the possibility to extend the follow-up up to mid-2018, but it will depend about extra fundings. In conclusions, real world is complex, and it's important to remind that trajectory of people could be between the trial, between Department of Health clinics, and then not everyone are choosing the same tools we are proposing to them. Therefore, the impact of interventions on the cascade and therefore on HIV incidence takes time. We can't expect to have a big impact on the last step of the cascade in 6 months. It will take 1 year, 1 year and a half. When I saw the cascade, you have people who have just been referred 2 weeks before. So of course, they are not yet in clinics and not yet on treatment. But can we reach 90 at population level in real world? This is a big question. And in that case, which services, tools do we have to propose in the comprehensive HIV intervention package? In that case, that will be the impact on HIV incidence and also at what cost. So just to remind that our primary objective remains to demonstrate that a UTT approach can reduce HIV incidence at population level, and the target date to close the trial is still June 2016, at least on that question.